Good afternoon, everybody. Thank you for joining us in our first webinar for the EHDEN Roadshow. Today's webinar is called The Need for Health Data in the Era of COVID-19. My name is Dwayne Schultes, and I'm the Managing Director of Vital Transformation. I'd like to thank you for joining us this afternoon. To begin, if you're having issues with your audio quality before we get started, please click on the little arrow next to the mute button and this menu will pop up and you can switch to the telephone. If you're having bandwidth issues, we do want you to participate. Please feel free to dial in and we look forward to having your participation. Just go ahead and dial in at that point and switch from the computer audio to the phone audio. And as well, we've had several hundred of you register for the webinar today. We're very grateful for your participation. Thank you, but we do want your input. So please use the question bar in the menu at the bottom, submit your questions, and we will filter them through the panel, and we will answer them as we move forward through the webinar today. And again, thank you very much for your participation. The COVID-19 pandemic underscores the need for high-quality health data that is readily deployed. Europe's early epidemiological assessments projected infection and mortality rates orders of magnitude in error, and once the pandemic was in full swing, official statistics in most European countries underreported coronavirus-related deaths. Most recently, the retraction of 2 separate clinical studies for hydroxychloroquine, published in 2 top medical journals due to unreliable primary data, demonstrates the importance of data quality for assessing the vital need for new medicines. This session will offer distinct perspectives on how to address data problems such as these and how to steer health policy with clarity to minimize negative health outcomes for patients. And again, I'm very grateful to have the participation of an excellent panel. And I'd like to begin by introducing Raquel Yotti, who's the director of the National Health Institute Carlos III in Spain. Good afternoon, Raquel. How are you?
Good afternoon, Duan. Thank you for your kind introduction.
Thank you very much for your participation. I'd also like to introduce Rafael Begoya, the director of SI Health, and the former health minister of the Basque Country. Hello, Rafael. How are you, sir?
Hi, good afternoon. Thanks for having me.
Thank you for joining us, Rafael. And I'd also like to introduce George Ripchek from the Observational Health Data Sciences and Informatics Network in the United States. Good morning, George. Thank you.
Hey, thank you for inviting me.
It's a pleasure to have you here, George. We'd also like to welcome Xavier Kurtz from the European Medicines Agency. Bon après-midi, Xavier. Bonjour.
Hey, good afternoon to everyone.
Thank you for joining us, Xavier. And finally, Danny Perito Alhambra from the European Health Data and Evidence Network, EHDEN, representing the project. Good afternoon, Danny. How are you?
Good afternoon. It's a pleasure to be here.
Thank you. So to begin, we'd like to start with an overview of what EHDEN is and what Odyssey is. And I'd like to begin by allowing George to give us an overview of that. So George, the floor is yours. Thank you very much.
Thank you. So Observational Health Data Sciences and Informatics, as we say, Odyssey, has a mission to improve health by empowering the community to collaboratively generate evidence that improves health. Here's a picture of our collaborators, 300 collaborators from 30 different countries, and data on about 600 million unique patients from around the world in over 100 databases. So they're getting near about 10% of the world's population. It's a complete open science effort, not just open source software, but everything we do is immediately available. How do you collect data on 1/10 of the world population? Well, you don't. What you do, you leave the data in place, convert it to a common data model, distribute the query to all the participants, they send back the results, and we collaboratively interpret the results and publish them together. Here's a picture of the common data model, and here is the extensive vocabulary that we use to gather data from all nations around the world. We have a very strong focus on data quality and data curation. Now, if we look, the problem with the literature didn't just start with COVID. Here's same question, same database, same month, 2 top journals, opposite conclusions. If you look at the literature, that blank triangle on the top there are very few not significant studies. 85% of published observational studies are positive, and that shows publication bias. And I won't go into details, but also p-value hacking. What does Odyssey do to address reproducibility and reliability? First, modern confounding adjustment using large scale, not regular, but large scale propensity adjustment. Second, we use many, many negative controls to confirm our results. We use many databases to improve our generalizability and reliability across locations and practice types. We are completely open. and we test hypotheses at scale so that we can see how we're doing. When we use this approach, we get pictures that look like this, which are more what we would expect to happen, with 6% of outcomes. When we say something is positive, there's a much better chance that it's actually positive than in the literature. How do we use it? Well, here's an example of the hypertension guideline, US about 3 years ago, European guideline about 2 years ago. This figure on the left, you see, this is what evidence was used to generate those guidelines. On the left, you see randomized trials. The dots are the drugs. Most of that guideline is expert opinion, not evidence-based. With Odyssey, we can fill in that diagram and have that much denser figure on the right, which shows all the studies that we did in Odyssey to validate the guideline. I won't go through the evidence today, but it largely confirmed the guideline, so that was good news, although it did show that thiazide and thiazide-like diuretics were better than ACE inhibitors, and the latter are used by over 40% of the world's population, so it was interesting. Our results are being published in top journals, Lancet, JAMA Internal Medicine. We just had one in JAMA the other day, PNAS, etc. If you want to learn more about Odyssey, we wrote a book about it, freely available on the internet. And our annual symposium will take place in about a week and a half. And that's it. Thank you, Dwayne.
That's really impressive. That's 19 slides in almost no time at all, George. Well done. Thank you. That's excellent. I'd like to pass the floor now to Danny Alhambra, who works with Eden and sort of applies Odyssey in practice. So Danny, the floor is yours. Thank you.
Thank you, Dwayne. We can go to the next slide, please. Yeah, I'm going to start by saying that with the COVID pandemic, we have been standing in the shoulders of giants. We have leveraged a lot in Europe from colleagues all across the globe and of course from Odyssey. And I'm going to take a second to acknowledge that and also to acknowledge the work of the colleagues in Eden who are now, as we speak, mapping and harmonizing data from 25 new data sources in Europe, including a few from Spain, France, England, and Scandinavian regions that will be available to identify important questions and to reveal important answers regarding the COVID pandemic. Next slide, please. So what do we do with this data? What's the idea? We are looking at characterizing people, looking at what happens to people when they get infected with COVID-19 or hospitalized with COVID-19. We do work on prediction, which is basically trying to address what will happen to a given patient based on their clinical characteristics and social demographics. And finally, we do causal inference or population level effect estimation. And I'm going to give you one example of each of these three. If we go to the next slide, please. This is the first study we finalized after we started collating all these data on COVID-19. This is a characterization study looking at all people hospitalized with COVID-19 in 3 databases from Europe, North America, and Asia. We more than 34,000 people, and we basically found very early on, this is something we put out there in a preprint in early April, that COVID is no flu at all. The patients admitted with COVID are healthier, they have less previous drug use, and they have less comorbidity in general, with the only exceptions of obesity, diabetes, and osteoarthritis. Next slide, please. An example of population level effect estimation, or in this case, drug safety. We leverage from retrospective data on patients who had taken hydroxychloroquine for other indications, in this case in particular, rheumatoid arthritis, and we analyzed more than 900,000 patients who were taking that medicine and found there was a double risk of cardiovascular mortality when that drug was combined with azithromycin, which was also being heavily used to treat COVID-19 across Europe. And finally, my last slide. This is a prediction tool, very simple prediction tool that we developed using data, again, from North America, Spain, and South Korea. And this has now impacted clinical practice and public health responses in many ways. In particular, there are some areas of Spain, like Catalonia, who are using this score to identify where a new outbreak has a high impact or is likely to have a high impact on public health and on bed occupation and healthcare resource use. I think this is an excellent example of how real-world data can be leveraged to inform the pandemic. I'll stop there for now. Thank you.
Thank you very much, Danny. So we've seen the tools available to us through Eden and Odyssey. And then the question is, how do we actually apply these in practice? So I'd like to give the floor now to Dr. Raquel Yati from the National Institute of Health, Carlos III. And Raquel, the floor is yours. Thank you.
Thank you, Duan. I'd like to start explaining for not the Spanish people what is the National Institute of Health Carlos III. This is the main public funding organization for biomedical research in Spain and also serves as a public institute of health, providing scientific and technical support to the national health system. The pandemic indeed has exposed the need for generating, integrating, sharing, and using data for research and public health purposes. These are the demands that our institution has been trying to meet during these difficult times by creating an urgent response. During the very first phase of the pandemic in March, we focused on the urgent need for generating evidence by launching an international immediate call for research projects. This early funding and coordination effort allowed clinical investigators to register real-world data from thousands of patients with COVID-19 and also to initiate different collaborative cohorts in the whole country. In addition, in order to meet the need for integrating and sharing data, funding was formally linked to the obligation to incorporate the data into a national database according to mandatory open science criteria. And in order to do so, we created a national COVID-19 database. And now we are in the very, very complex process of gathering all cohorts and extracting and integrating data for different sources to make it accessible for the whole scientific community. This effort, this national information will be integrated into the EU COVID-19 data portal. Finally, we are promoting the use of data and evidence to achieve the application of in the clinical setting, to identify new research line following a data-driven approach, and also to support an adequate decision-making process for public health and public policies evaluation. Next slide, please. And regarding surveillance and public health, it is important to consider that Spain has a very decentralized health system where regions are the direct providers of health services to citizens. And in this scenario, coordinating responses to fight COVID-19 has been a huge challenge, but also an opportunity to improve procedures and foster collaboration. I do believe that our national-wide population-based seroprevalence study performed in close collaboration with the 17 Spanish regions is not only a good example of rigorous research with a great impact on society, but also an example of a notorious coordination and data integration effort. And in the forthcoming phase of the economic recovery, I think that managing and using data and evidence will be crucial in achieving policy goals. So now looking forward, we have the opportunity and the responsibility to do it better. Thank you, Duan.
Thank you very much, Raquel. It's a pleasure to have you here. We'd also like to look at this issue from the level of the regions, and we're very pleased to have Rafael Bengoa, the former head of healthcare in the Basque country. Rafael, the floor is yours. Thank you.
Thank you. Thank you, Dwayne. I'd just like to have a go at this, but from a regional level, but policy perspective, and how what has happened with COVID can encourage us to take sort of a stronger stance in relation to how we use information. Because of course, decision makers need to have a pretty different source and at least a more robust decision-making process than they have had. I just want to show that this person, of course, is receiving fragmented care. This is still happening just about everywhere. And we know about this fragmentation. We don't need more data on that. We know the inequalities that are around in Spain, Basque Country, and other places in the world. So we just know that that has been deadly. So we don't need much more information in relation to that. Let me just see if the next one. Oh, here it is. So it looks like it's not clicking in here. So I won't go through all the things that all countries are trying to do at the policy level, both in general in terms of the focus they're giving to the different policies they're doing, within which there's, of course, an expanded use of information and communication technology. But COVID has reinforced the need for integration and a population focus. So what I am saying is that you're obviously going to need data and information to be feeding the next, let's say, post-pandemic population focus that we need in countries. So are you passing it for me?
Yes, I'm moving the slide forward.
So I think we've all seen how COVID has been an enabler of integration and also of launching of new, of course, information, as we've just seen. I won't go through all these rapid shifts that have happened because we're all aware of them, but they all have to do, all of them have to do with data management. Next, because I'm not, now, if we're moving towards population health, it means, at least in my perspective, that policymakers is going to be moving towards much more of a proactive and outreach community and home care model, which requires, of course, a completely different person-centered services and technology. And of course, that's going to require a shift to completely different and more data-driven and remote models of care. If we are going to be in more remote models of care, we need to, we need to make sure that we know how to use all the tools that data information is already giving us to manage a population. This is just an example from the US about how to manage the risk stratification of people. But again, we know how to manage these things. We know how to manage population health. And if we're moving now in this next phase post-COVID into population health, which is absolutely essential if we want to get our act together, then we need to be able to use all these tools and information. Next. Fragmented care systems, at least at the regional level, when I was minister here, it just meant complete siloed data completely fragmented from each other. Nobody at the policy level can usefully get that, let's say, picture together. If we consider a system is about collecting data and information, Spain is moving forward, but interoperability is still unaccomplished. So we're having a lot of problems of bringing this information together. If there's no interoperability, there's not going to be integration of care. And some countries were saying 10 years ago when we started all this to try and get the picture of what's happening in information terms in a population in order to plan better. Many people are saying, well, that's going to be resolved by the market. Interoperability is going to be resolved by the market. That did not happen. So I'm just saying, I think now what we need is market, but we also need, obviously, some planning in relation to, in order to accelerate that interoperability. Next, last one, I think. And this, I'm just bringing this up because it came up last week in a big meeting in Europe. But basically, what these people are saying in terms of RCTs, as you can see at the top level, you can do all the evidence-based practice you want, and that has been possible in relation to some of the drugs that are being used in COVID on a day-to-day today. But it has not been possible, of course, to do at the speed necessary RCTs on other things like wearing masks, etc., face masks, etc. So we do have to lean at the policy level, not necessarily at the scientific level, on some observational evidence, and understand that the sum of the two of this evidence-based practice, RCTs, and a practice-based evidence is one thing which we need to be able to understand in these very tough epidemiological situations. And we've had a lot of bad decision making, both internationally and nationally, because we were not using observational evidence and everybody was waiting for some sort of massive RCT in relation to some of the decisions that had to be taken. And that at the policy level is not useful. Thank you.
Thank you very much, Rafael. We'd like to move now to our final presentation, and we'd like to then look at this from the perspective of once you have all the information and what you need to make decisions. Obviously, if we have a drug, it needs to go to the European Medicines Agency. So Xavier Kurz, please, why don't you fill us in on what's going on? The floor is yours.
Yes, thank you. COVID-19 situation has actually highlighted difficulties for the use of real-world data for medicines regulation and evaluation. First of all, it has illustrated the fact that hypotheses based on weak observational evidence may have public health impact and public health consequences and detrimental public health consequences and impact on cost. Even we can consider what are the number of studies that have been initiated based on the weak observational evidence on hydroxychloroquine. It's very important. It has also highlighted the need to focus and to highlight, to make attention to the validity of the data sources. And this and the service fair story has, of course, been a very illustrative example. And also it has really led the regulators to think about the role of real-world evidence in medicine evaluation, and especially the place of real-world evidence in comparison to clinical trials. So this situation has exacerbated questions and uncertainties regarding the use of real-world evidence in medicines regulation. And can I go back here? And so the way we are now is that, of course, we know that the field of pharmacoepidemiology and observational evidence is mature and used for decades for safety evaluation of medicine products, but the use of for efficacy and effectiveness is debated. And so we received, we are still in the same situation where we receive questions regarding the situations where observational health data would be acceptable by regulators for the benefit risk of evaluation. And we still have the same responses, typical responses. This is on a case-by-case basis, that the health data may be supportive, but may not replace randomized clinical trials, and the observational evidence may be used and is accepted in exceptional circumstances. We need to give considerations to effect size and medical needs and the different situations and the product. And we generally then recommend to apply for scientific advice. So there are general criteria for acceptability that we provide, and these are standard criteria that we think are important. Evidence should be adequate in terms of precision of effect, adequate range of characteristics and data elements. It should be derived from real-world data source of demonstrated good quality, and the validation of the data source is a very important element. To be accurate, valid, based on the best epidemiological and statistical methods, and consistent across countries or data source, or the difference can be explained. Replicable, which means that there should be the transparency of the methods that have been applied, and also timely in order to be used for medicines evaluations. Now, can we learn from experience? Just to tell you that we are now reviewing the observational evidence submitted in marketing authorization application and type 2 variations over a period of 2 years, 2018 and 19. And so we are doing actually more a repository, an inventory of all the data, observational data, real-world evidence that has been submitted, even if for those projects that have not been, for which there has been a negative opinion, or for which have been withdrawn. So we do a manual review of all CHMP assessment reports with management plans, and we do this inventory of information, and we will then do analysis of what are important, what are the elements that may drive the acceptability of real-world evidence, and what are the objectives of these submissions. Just has some very preliminary observation, and these are only personal observation from what I've seen so far, is that the majority of observational evidence submitted is related to plan studies in risk management plans. But then when we look at the acceptability of this information, in very important elements in the assessments is the quality of the data source and of the data elements. And as I already mentioned, the demonstration of this quality and of the validation of this information, and also the use of best practice in epidemiology and statistics. And we have to say that there are cases indeed where statistical and epidemiological methodology is not optimal, and therefore there are issues in the method that have been used. And then it seems as if in some cases, it seems that the issue of selection information bias, small sample size, issues of quality of the data, and issues of data analysis are really insurmountable obstacles for the use of observational evidence for supportive evidence for efficacy and effectiveness. So I think that probably still a lot of work to be done in order to ensure that real-world data, healthcare data, has observational evidence can be used and widely used in medicines regulation. And this is my last slide. Thank you.
Thank you very much, Xavier. It's a pleasure to have you here. And then you brought up some interesting points. I'm going to bring everybody in now so we can take questions. I'd like to remind everybody, we are taking questions from the audience. Please use the Q&A button at the bottom of your control panel, and we will filter the questions to the panel. Now, Xavier brought up some interesting points from his perspective at the regulatory level. The data is not reliable. It's not, the models aren't necessarily working. EHDEN's purpose is to strive to use the right data at the right time to answer the right question. Practically, then, it seems like there's a gap between what is possible technically and what we're getting at EMA. Danny, I'd like to start with you. How can EHDEN fulfill some of the questions that Xavier brought up at the end of his presentation?
Yeah, so EHDEN, again, and all the leverage that we get from Odyssey strikes to basically produce the evidence that regulators and other stakeholders, of course, need in a very timely manner. So I think the example that I gave about hydroxychloroquine is a good example of a study that we completed within a couple of weeks of the initiation of the pandemic that actually resulted, or at least was cited in some of the regulatory warnings that came out from the EMA and also from the FDA and other regulators. So I think we are basically striving to have an agenda of speed, but also quality, transparency, and reproducibility. And we make sure that all our data elements, all our cohort definitions, cohort code lists, all our analytical code is made public. And we follow always standard practices to make sure that we fulfill all those criteria.
Thank you. Xavier, I just have a follow-up question to your presentation. Is the EMA collecting specific safety data around COVID-19, or are you looking for specific safety data to be delivered? Is this something that's a mission right now?
Yeah, we have initiated a number of projects that we are funding regarding COVID-19. First of all, in terms of some categories of products that are being used, like the steroids. We are also preparing the data collection on vaccines as soon as they will be used. So that's within that, indeed, based on the lessons learned from the H1N1 pandemic, we need to be ready as soon as the vaccines will be used. So this is one of the activities that we are busy with now. And so, yeah, and we are following, depending on what are the issues that are coming on, we are following them and then doing analysis.
Thank you. I have a quick question then for Raphael following up this. If we look at, you mentioned the interoperability and the lack of, or the siloed data causing problems. How does a platform like EHDEN, in your perspective, going to cross these barriers? Is this something that you think is key or would be useful? You're muted, Rafael. I'm sorry. If you could unmute yourself, that'd be great. Thank you.
If we haven't seen interoperability, at least in Spain and several other countries that we know, successfully integrate some of the pieces that we need to integrate, forget COVID, just on the day-to-day management of healthcare. We haven't seen it because a lot of people, and that's what I was mentioning, a lot of people are saying the market's going to fix that. And the market did not fix it because today, it's 10 years after, and that hasn't happened. And I'm talking about both Central European countries and NHS type of models, which means that we need some sort of planning approach. And I suppose Eden can perhaps suggest what is the planning approach that a government could be using in order to accelerate interoperability instead of waiting for something magical to happen, because it isn't happening.
Okay, thank you. I'd like to just launch a poll here just quickly, looking at who needs the data and where the decision should lie. And I'd like to allow our panelists to vote as well. We're just quickly saying, where should the policy decision live? Where should this data go? And we'd like to ask our audience, we have a very broad audience. So who should decide? Should it be the EU institutions, the member states, the regional health authorities, practitioners, or at the individual level? So we very much look forward to you. There's 150 of you out there. Please feel free to answer that, and I'll continue to leave that open for a little bit. Let's see, Raquel, we have a question here regarding the Institute. Is the registry on COVID integrating data from all Spanish regions? And if it is it available for conducting studies to academia and the private organizations? What's the current status of the data you've been collecting on COVID-19?
The data that is collected is in a first stage is from the projects that we are funded. So there is a mandatory under the regulation that we funded those projects. There is a kind of obligation to deposit the data in the repository, but it is open to other projects. So now in the first phase, we started with the project that we funded, but we expect to increase our database with other projects because the structure is something that it was thought to put together all science and facilitate to make the data available to all the scientific community.
Thank you, Raquel. And I should say that question came in from Marcella Riviera. Thank you very much, Marcella. If you have a question, please submit it in the question bar. We will try to answer them as we move through. I'd like to put this poll up because it's interesting. Boy, oh boy, this is a tough one, isn't it? George, I'm going to come to you about this. So essentially, we have sort of a three-way split here between government, member states, and regional health. How does Odyssey fulfill the mandate here? Because it looks like we can't have a clear decision. It looks like you're going to need to fulfill three major stakeholders here. How could Odyssey play in that?
Well, first of all, Odyssey does not create a central database. That scares everybody. Data where it started. In some cases, that place is a healthcare institution. In some case, it's a government agency. In some cases, it's a company. We leave those data behind the firewall. It's a voluntary network, so we ask people to participate. They participate as they decide. And that allows us, and it's made people feel comfortable so we could aggregate such a large data set. So I think it's that, and the laws say for data sharing, just taking that example, between say Germany and Taiwan or South Korea are very different, and we can accommodate all the different cultures of privacy and security, by allowing people to control their own data.
Thank you very much. We have a question here from Anya Schiel, who's a statistician, works for the Norwegian HTA. How do you handle a large number of retractions when it comes to published data on COVID-19? So how do you deal with the withdrawals? Danny, I'll come to you on that. How do you deal with retractions of studies? How does that move the bar related to your evidence base?
Yeah, so I think as George showed in his previous slides, there are many issues with research, replicability, validity, and many others. I think Xavier has also mentioned some of these. I think the only way to improve this is by basically creating a pipeline that is reproducible and that is very clear in terms of data provenance. The issue of the retractions of COVID-19 related research is an issue of basically the use of data that is not known in terms of provenance. So it's potentially fake data, or at least data that nobody knows about. We have very clear rules for provenance, and we know where each data set that we are analyzing comes from.
And Xavier, I'd like to come back to you then. If you had, it seems like from your presentation, the problem is data quality. That seems to be the real issue right now, that you have concerns at EMA. If you had a pure audit trail and higher data quality with observational data, do you think that would then be more beneficial to what you're trying to do? And would that help you with results?
Yes, but what is very useful if we have also for the data sources some track of publication, but also validation studies and standard information that can be accessible and in advance, and for which can describe the data source and can describe the methodologies. And this is, as it was mentioned by Danny, transparency on the data source is extremely important. But as I sort of saw in my presentation, a demonstration of their quality is validation studies or other types of information is very important. Otherwise, we cannot really rely on the information.
That's great. Thank you very much. We have another question here that I'd like to ask. A lot of the models that were used by public health authorities were very, very wrong, which impacted decision making. And Raphael, I'd like to come back to you. How could we use, if you had the tool like an Odyssey network available to you, how could that do a better job getting around some of these public health estimates that were so wrong? How would you want to leverage that practically from a perspective of a regional health authority, for example?
I think we should have a database of course, of what has worked this time around, so that we can access it next time. But what has been happening in public health decision making has been all this zigzagging, also in WHO and at country level, in terms of what to do with different public health interventions, which scientifically makes sense because you are learning as you go. But at the end, it has created a level of confusion, and it has downgraded the credibility that science has. I'm talking about the public health ones, not the RCTs that were handled very quickly and correctly with medicine. Nor am I talking about Raquel Goyi's excellent serological study, which actually went quite quickly and was one of the first in the world. But on public health measures of what had to be done and decided quickly in terms of public health, there was just too much doubt. And then, the first thing I think we have to try and understand better how, of course, to feed politicians. And I think one of the things, I don't know which of the organizations which are participating, but one of the things we have to figure out is not with demagogic, of course, politicians, because those are just trying to fit data to fit their narrative, but with serious decision makers that are leaning on science. That didn't work very well either. So even if you're leaning on science in terms of decision making, if you're a politician and you see all this zigzagging from science, so I think science has to look at itself in relation to the public health data that it was using in order to take decisions. So how to get around that, I'm not sure. I'm just saying that this time around it didn't work. There was too many doubts in the air.
Yes, because if you remember on March 16th, I believe, Stat magazine published a study from Johnny and Edis at Stanford that looked at the Diamond Princess cruise line and came with infection rates actually quite close to where we are now with the age distribution. But then a week later, Nigel Ferguson, the study came out of Imperial College that was looking at 2 million deaths at the U.S. alone, and that sort of really changed. And that gets to that ping-ponging that you're talking about, Raphael. Raquel, from your perspective, how are you managing this? Because ultimately, your institute's supposed to be at the total member state level. How do you deal with the conflicting data that's hitting you? What would be more beneficial to help your decision making?
the first thing I'd like to say is that we have seen a very huge improvement since March. And I think it is something that it's important to say, because during this time, things has changed. In March, the first thing we didn't have was data. There was only assumptions, hypotheses, and all the conclusions were based on very weak data. But now, I think that the situation is different. So now we have models that are strong enough to make conclusions because we have data, and we are not only relying on assumptions. So this is the first thing I want to say, because not everything is so bad. So we have learned, and we need to keep learning. The second thing that I think it's important is that we need to focus not only in technology and interoperability, that is very, very important, but also and mainly in human resources. It's very important to strengthen scientific and technical capabilities within the public health departments and at the regional and also in the central level, including our institution, because we need talent, and public health is an area that has been, I think, not enough considered during the last decade. And we need to incorporate as well independent experts in the decision-making process. So it's not only a problem related to technology or structures or even public health centers. It's something related to talent and to human resources, to experts that can that have the ability to make this process better and more reliable.
I'd like to pick up on that talent point, and also because this is something that Xavier was talking about statistical modeling. George and Danny, I'm going to come to both of you. I'll start with you, George. Are we saying that practitioners are ultimately going to have to become quants? I mean, are we saying that we're going to need to increase the mathematical capability of practitioners or people who are dealing with the data? I mean, or is what Raquel said, just outsourcing it to qualified practitioners, is that enough? What's your opinion on that, George?
I think that well, in our medical school at Columbia, we are teaching a little bit more data science, but we're not expecting everyone to become analysts. They need to be able to interpret the literature. They need to be able to read an article and kind of have a gut, not a gut feeling, but an experience-based assessment of whether that's good evidence or not. And you can tell some of the papers that we've read in COVID in the last 6 months, you could tell just in reading it that, you know, something is perhaps wrong here. Not all of them that were bad, but in some of them. So we teach our students that. And then there needs to be a level of trust between the practitioners and the scientists who generate the evidence. And you know, if the practitioners understand the zigzag as part of science, then at least the practitioners will know how to interpret it and realize that, you know, we don't have the answer yet because we don't have any data yet, as we just said, you know, in March, and we're doing the best we can. So I think it's an understanding of the scientific process can do a lot to build the trust so that we can use those evidence.
And Danny, you're a practitioner and a bit of a quant. Which leg do you feel is more strong right now? Which side of the equation are you on?
Definitely the latter. No, I believe that you know, something that's quite important is that this is not only about having data and producing actionable data, but then also about interpreting such, you know, publications and such science and acting on it. And you know, physicians are trained for years to learn how to interpret data from a randomized controlled trial or an observational study before they make decisions that inform their practice, and still sometimes they get it wrong. And I think we are experiencing here a situation where politicians are due to make decisions sometimes based on contradictory data without having any training on how to interpret that data or appraise a publication. So that example that you gave about Neil Ferguson's paper is a really good one, right? So that's only a model based on simulated data that basically changed the world. And you know, those of us who are in the business of data sciences could read that paper and understand what was going on in there, but the people who were making decisions didn't. And we can of course blame them, but that's very easy. We also need to find a mechanism to protect decision makers from flawed data, from flawed studies.
And what's so fascinating though is because you had the John Ioannidis article in Stat and the Neil Ferguson that came out within a week of each other, and it seems like we all went that way. Everyone went one direction and no one looked at the other one, which was also based on hard data. Xavier, coming back to you, what would you be looking for methodologically? What do you think is the key problem that we have now related to observational data that you'd like fixed? I mean, if you're looking at a package, what's the one thing that you think would help solving an observational data package from your perspective at EMA?
Well, probably that the most important problem that we have when we look at and analyze observational data in terms of comparisons is the issue of confounding by indication.
Yeah.
And this is, in my last slide, I mentioned some nearly unsurmountable obstacles, and confounding by indication is a nearly unsurmountable obstacle. So there is then therefore the need for really making some balance between are the limitation of the data acceptable in view of the public health need for having that product accepted or not, and for the amount of information that is needed for the evaluation. I think this is something that is existing in now. Of course, for safety it is less important, but whenever there is a use for observational data as a supporting evidence for real world for efficacy mainly, it's a very big important problem.
Yeah, but then of course the other issue is then you put in you want an inclusion criteria, but I've never seen a 65-year-old obese person in a cardiovascular trial. So then you can bias the clinical study too.
Then you have endless discussions about methods of using propensity scores and modeling, matching, and so on. And so there is a very large amount of time that you spend on that. So on how to do that.
Thank you. Let's move a little bit controversial, shall we? I'd like to look at a question for you here. So we're talking about data flow and data information and opinions. Was Sweden's herd immunity approach the correct one? Yes or no? This will be interesting. Be very interesting to see where this lands. Okay, so we'll let that cook along here and continue. One of the problems we see in Europe, we see that data centers and data access is often controlled at the academic level by a researcher who may be using this for political leverage or political power. And by definition, if an academic is paid by the state, they're a bureaucrat. How do we deal around sharing data in Europe, which is often politicized due to the nature of the structure of healthcare? How do we get around that? Danny, I'll start with you as an academic who does research. How do we get around the politicization of data where someone may carve out a political power within a major hospital just by having access to this data?
Yeah, I think that's a very, this is all a socio-technical construct, not really a technical alone issue. I think there are many formulae that have been tested in different places of Europe. You have, of course, the Nordic registries that are centrally governed by the government or stats authorities. You have the system we have in the UK with, for instance, CPRD, which is handled by the regulator. And you have places like Spain where you have each region having access to some data and then handling it differently in different regions. I think there's a fine balance between access to data and privacy and data regulation issues. And Europe has to find a way to make data actionable quickly and to make sure that the right data is ready at the right time. In EHDEN, our approach is basically to work with people who know and have access to data rather than try and grab data ourselves. And that is proving quite successful to date. We have data, we are mapping data for over 120 million citizens in Europe. And we will hope that our colleagues from all over Europe will be willing to participate in studies when they are relevant. And I think, that is also something important, that the questions you have to ask have to be relevant for public health.
Thank you, Danny. I'm going to share the results of our survey. So the overwhelming majority of us on this call think that Sweden was wrong. But although I think many countries would wish they had herd immunity right now. So it's an interesting one. Thank you very much, everyone who participated in that poll. We have a question here from Nigel Hughes, the head of the Eden Project. And I'll start with you, Raquel. Do you think we'll make more progress in 2020 to 2030 than we did in 2010 to 2020 with regards to moving into a learning health system? What do you think, Raquel?
I expect so.
We hope so.
I hope so. And I think this crisis, the COVID-19 pandemic, is something that in some way is going to accelerate change. So I think that in these few months, we have talked about the need for sharing and the importance of science and data and evidence more than in the last decade. So I hope and I really think that we are going to go forward fast.
George, I'm going to ask you the same question. Given you're dealing with Odyssey and the infrastructure side, do you think we'll make more progress in the next 10 years than the last 10 years? I mean, we did do a lot of progress in the last 10 years. Let's not kid ourselves. It's been huge innovation. But what do you think? Do you think we'll go faster now?
Well, we always think so, and we certainly write that in our grant proposals. I think, first of all, we've made a lot of progress, and I think that where we are today, where we were able to spin up an initiative to look at COVID pretty quickly, does reflect it. I know things went poorly, so now we know what we need to fix. Unfortunately, we had to test that infrastructure. Now we see all its weaknesses. So yes, I think so. I think a lot of this is creating a culture that wants to do this. And actually just going back for a second, I mean, the culture of Odyssey is a culture of a very self-critical culture. You get data that's less than half the battle. Then you have to validate the data. That's more than half the work. You run your methods to do causal inference or everything, and then traditionally what you do, you send it into the editors, and if the reviewers don't reject it, it must be good. Odyssey, actually, that's where it starts, and then it looks at it and says, okay, did we do a good job? We had a number of diagnostics say, did we do it right? And I think that's an important part of the health, the learning health system that Nigel's asking about. And there are many questions we won't answer. So we have this database, we're sitting on it. There are things we'd like to answer, but we say, you know something, our methods will not produce reliable results on that. And we don't do that. So I think that cultural, the looking forward to what we can accomplish while still being careful and self-critical, I think will be the most useful in the next 10 years.
That's great. Thank you. Ladies and gentlemen, believe it or not, we're down to our last 4 minutes. We are almost out of time. And questions are still flowing in, and I think we could probably go for another hour, but unfortunately, we cannot do that. So we're going to have to call this to an end. I do have one question I would like to ask each panelist, and if the panelists could keep it to, a minute or shorter. But I'd like to ask each of you, if each of you could and had a magic wand, what single regulatory infrastructure or policy change would you make in the next 6 months to improve data-driven public health decision-making? So you have a magic wand and you have complete carte blanche. What would you like to do? Xavier, I'll start with you from the regulator side. What would you like to see done, Xavier? You're muted, Xavier. If you could unmute yourself, please. Xavier,
what I would like to see done, so this is not really in terms of regulatory action, but I would like to have a set of data that are being made public on each data source. And this is when I say that it is a standard set of harmonized data that would be collected on each data source, that it would describe each data source, so that regulators would be able to know which data source is relevant and adequate for a given research purpose.
Thank you, Xavier. Danny, from your perspective, what would you like to see done?
I think because you're saying in the next 6 months, and I believe we are still going to be dealing with COVID by then.
Yeah.
I'm going to say I would love to see the European Union creating something similar to the CDC in the US, an organism that could handle data from all the countries in Europe and make or inform decisions based on the data that's collected for the COVID-19 pandemic.
And then have central funding from the EU sort of as a, yeah.
Absolutely.
Yeah. Raphael, from your perspective, what would you like, sir?
Yeah, that would be a good idea. The other, the point I have is on capacity. I think the academic world, with all of the knowledge, the learning, ends up building a career around, let's say, the incentives you have within the academic field. And one of the incentives is not, although most academics would like that, is not close enough to policy making. So I think there's some people have been working on how can whatever organization we build in Europe make sure that the academics that are learning, studying, doing all the studies are actually being able to have a career by being close to policy making, not hidden in some universities, and some papers unfortunately never read, although they're fantastic papers by policymakers.
That's a great point. Thank you. George, from your perspective, what regulatory decision or what policy decision would you like to see in order to implement better data?
Well, it hasn't been mentioned yet, and this is more than 6 months, but I would like to be able to explain to the public the value of using these data so that the public feels comfortable with sharing their data and seeing it as a public duty that these data, in a safe way, get used for these research purposes. I mean, we're saving lives, hopefully, with these data, and so it's about privacy.
Thank you. And Raquel, the last word to you. What would you like to see happen?
Difficult to be the last one but I share absolutely your vision. And I think we need a systemic change. So it's difficult to choose only one action. But if I have to choose, I think that the most important factor is having adequate human resources within the administration. So I share a vision with Raphael. I think it's important to have people that have the talent and the knowledge to make things happen. So in the following 6 months, this will be the most important aspect for me to take care of.
Thank you, Raquel, and thank you, the rest of the panel, and thank you, audience, for your participation. We've come to the end of this first EHDEN Roadshow webinar. We have 2 more. Please go to bettersciencebetterhealth.com and click on the EHDEN Roadshow and register for our next 2 webinars. And ladies and gentlemen on the panel, thank you very much for your participation today. It's been a great panel. For the audience, thank you. And we call this session to a close. Thank you very much. Have a good afternoon.
Take care.
Bye-bye.